Hello and welcome to the webinar, Realigning Services, Working with Families to Realize the Value of Community-Based Options. You may submit questions and comments into the chat box throughout the presentation, as well as introduce yourself in the chat box with your name and state. And it is now my pleasure to turn the call over to Leah Holmes-Belina. Please go ahead.
Thanks, Bailey. Welcome, everybody. Bailey so nicely introduced today's session. It's my pleasure to introduce Pat Hunt. She's the Executive Director of FREDLA, which is the Family-Run Executive Directors Leadership Association. And we look forward to spending the next hour with all of you. Pat?
Thank you so much. And thanks to everyone who has joined today. And thank you to everyone at NASHBID for supporting us in this effort. It's nice to join you for this third opportunity to have a discussion. And today we're going to talk about working with families to really realize the value of community-based options. And I suspect some of you have joined because you might like to learn a little bit more about some strategies for advancing or making changes to the services that you have. Next slide, please. So we thought we'd start this off with a poll. So what kinds of services would you like to increase for children? And we've only given you a few choices here. So if you have others, please add them to the chat box and I'll rely on one of our NASHBID partners to tell me what's in the chat box. So take a minute to think about what is it that you'd like to increase? And maybe we can see the results of that in a minute.
Still have some answers trickling in, so just a few more seconds.
Sure. Those are hard choices anyway, right? We want more of everything.
And here are your results.
Screening, diagnostic. Nice mix. Mobile crisis, is there anything in the chat box? Mobile crisis and screening are at a tie.
So we have respite written in the chat.
Okay. Great, thank you. I love it that you came to this meeting really knowing what it is you'd like to change, what you'd like to have more of. We can go to the next slide. We'll talk a little bit about the objectives of today. Really, it's about strategies for engaging families before redesign meets resistance. And I think many of us have had experiences where we make great plans. We engage the people we think we should engage to try to move forward and make change happen. And then we meet resistance, whether it's from policymakers, whether it's a state organization that doesn't think the direction is a great direction, whether it's a particular legislator, whether it's families, whether it's providers. We've all had the experience, I think, where we have to go back to the drawing board because, whoops, we left somebody out of the conversation. The second thing is a tool to help families make an informed choice about out-of-home care. And we developed a publication in response to what's happening currently for families. And third, we'll share one practical method that has been used in the state for planning for children to return not only to their home states, but to their homes. And next slide, please. Today's topic really is important because time is running out. It's limited for children. Pretty fast, children become young adults. And for those of us who have raised children, we know when they're 2 or 3 years old, we may feel like it's going slowly because of different life stages, but it all really does go pretty fast. We know that money does not necessarily equate to positive outcomes. Clearly, our country is at a tipping point when it comes to mental health services and supports for our children and their families. The demand outweighs the supply. And sort of that rapid profusion of funds that happened from the state to federal level during the last couple of years hasn't always been planful. It's been reactive. It's been great to have the money, but it would have been good sometimes if more planning happened ahead of time on both ends of the spectrum. And also with perhaps more attention to the capacity of SAMHSA to guide and oversee the results of the funding. I think oftentimes people new to their jobs has been turnover, as it has in many organizations and many provider agencies. We've seen turnover at the national and federal level as well. So I think everybody being up to speed would be really important in order to be able to move forward and develop things that need to be developed. And funding failure first for mental health in schools is just not the way to go. We don't always want children to be at risk of whatever, being out of home, being in the hospital, being kicked out of school, whatever, before we intervene and provide services to them. So I think today's picture is a picture of crisis, not only the crises that families are going through, but the workforce crisis, and all of us equally scrambling together to try to get people's needs met before they become so urgent that they're requiring deeper levels, more intensive levels, and more costly levels of service. And that all could have been prevented if we could intervene in time. So people who are talking about screening and finding out what's going on and getting their crisis systems running, I think that's kind of a balanced kind of approach that we need in your state. So thank you for being willing to share that information today. Next slide, please. So when we think about this work, we know that all of the changes have been put forth by well-intended people, but they have left many families to seek or demand those highly restrictive and intensive services. And programs, while this scenario may temporarily financially benefit programs that rely solely on a brick and mortar business model, it's unlikely they will even be able to keep pace. And so we know already those facilities where people are demanding, or I would say they're actually desperate enough to need at this point, some out-of-home care. Those are backing up as well. And we want children to succeed at home and in their communities. So really taking time to pause, pivot, and plan is really important. When we think about numerous children from the East Coast who may have an ocean view state like Massachusetts ending up in Utah for long stays, it just doesn't feel right. And it doesn't honor them and their life and their families and their connections to the world they know. So really taking this time to talk about ways that we can make changes and engage families in that is really key, I think, to moving forward. And we need to shift to a more balanced approach to meeting the needs sooner, with what and how much they need and when and where they need it. And while that may sound like well-rehearsed rhetoric, it's really been the refrain of families for generations, to the ballad of what we would call betrayal and broken promises, maybe by our country's systems, just because that's how it's worked. And many times we've been told to try things and things haven't worked, and families feel let down and disappointed. And we know that sometimes that can turn into other emotional reactions to people who should be their partners in care. Next slide, please. So I'm wondering what you see as your biggest challenge to making the change that you identified a couple minutes ago. What's your biggest challenge?
In just a few more moments with the poll, we're still getting a few answers.
Sure. As you think about making the change that you identified, whether it's in crisis services, whether it's in screening. What's your challenge? Knowing where to start. Financial constraints is big. So maybe in our discussions today would be important to talk about how to make changes that will free up some of those resources to reinvest in more community-based care to intervene sooner with children, youth, and families. 18% policies. Thank you. Thank you for sharing this. So let's talk, if you will change the slides, about engaging families in the process. And you can go to the next one. So a few basics before you engage families: really be clear about your motivation. The secret sauce for success is in identifying the who and why, right? Who's going to be engaged? What's the population you're looking at? Is it going to be by age? Is it going to be by issue? Is it going to be by, their diagnosis? What is it going to be about, and why? What's the compelling reason? What does data say, and what do family experiences say? So you have to learn about what are families experiencing once you think about the who. And families can actually help you think about the who. And then use data to inform your direction. Learn about fears, hopes, and dreams. It's not about which services are most families using. It's about what do they need and what gets in the way of their hopes and dreams. And I will tell you, families' hopes and dreams change by any given day. The longer they wait for services, the more their hopes and dreams change. They may start one day wanting for their child to be able to stay in school, to attend school. Maybe they're having a problem getting to school and participating in school. And if we wait long enough, they may have a dream that their child can come home from residential care. And if we wait even longer still before we intervene, they may have a hope that their child will not be couch surfing, that they'll be living home with them. And if we wait even longer before we intervene, they will be hoping that their child will be alive tomorrow. And so you can see how urgent this is in the timing for children. To plan incrementally, engagement is ongoing throughout the whole process of change. Engage families in determining why, and in part of the planning for how you're going to approach it, and being part of the solution and creating win-wins. Creating win-wins makes it be so that people don't then get in the way, right? Agendas, personal agendas get in the way. Next slide. So during keeping the family supported, and not all families will be eager for the change that you want to make. So making sure that you get a broad group of families involved in those conversations. Those families are not resistant, they're under-resourced, or they have been competing with other families for scarce resources. And so understand how that has happened within your system can help you understand better why they are feeling like they are. And it's probably important early on to have a meeting with just the families so they can begin to have those kinds of conversations that let them know that their voice is important, that this isn't about competition, that it isn't about one person being more important than another or one child being more important than another. Really listening and reframing the message. And rivalry among families or provider groups can undermine your best efforts. So it's really important to be inclusive. And after is on the next slide. So methods to find out the difference that your change is making once you've made change. Really find out the data and match it with some compelling stories from the families who have been engaged throughout. What difference has it made for their child? And gathering new data along with those compelling stories can be key to you keeping funding moving in a direction that you want it to move. To have routine feedback from families and family-run organizations, because they're serving most of the families that you serve in one way or another, either by training or family support or peer support, or families participating in their events. And to celebrate and promote your shared success. I think when families feel like they've really been part of the success, they can continue to be engaged and move forward with you. So we're going to move to this section that's about points for helping parents considering residential care. So in response to today's level of need, we recently released this publication for parents who are facing choices about residential care. And let me see if I can add a link to the chat box. If I can, that will be good. Yes. And you can download a copy of that publication at that link. So when families demand out of home interventions, and you just went through the process where you heard about the hopes and dreams, right? They inform the priorities. So sometimes more than one comes to the top, but really listening with empathy. We don't know anything about that which we have not experienced. I haven't worked for NASHBID. I don't know what it's like to work for NASHBID, right? There's lots of things I haven't experienced. I'm not a basketball player. And so really learning from people who are having the experience is really key. And ask what's the biggest thing getting in their way, because that's how you can begin to narrow down the things that you can change to make your goal happen, regardless of what your goal is. And if you know you don't have enough screening services, listening to families about the when it should have happened and how do you link sooner, and how do you use other funding to begin to develop and enhance those services is really key. So we'll have some tips for you on that in a few minutes. We can go to the next slide. I think I'm going to be a little quick going through some of these because I think our later slides are going to have maybe spark a little bit more response. The areas we covered in the publication that you now have a link to are those 8 areas. And the purpose of those areas was to reduce isolation and identify services that are available, including respite. For those of you who want to increase respite services, you can feel free to reach out to NASHBID, where we're going to provide 10 one-hour opportunities for one-to-one support for those of you who leave these 3 meetings with questions or want more follow-up. So that might be a topic that they would like to spend an hour talking with you about and helping you plan for. So you can see the topics we covered, and most importantly, number 8, we created a checklist of questions that they can ask when considering a residential option. And we really encourage families to interview potential programs and actually score them. That would be even nicer if there could be some competition. In today's moment, I bet there's probably not as many choices for families as we would like them to have. But I think them going through the process can help them understand maybe they should look for some community-based option before they make that decision. Next slide. The areas covered in our checklist include location. We know there's not always an opportunity close to home, and there are lots of challenges covered in our checklist to help people understand about locations, environments, safety. A tailored approach. Education is big. Real questions for them to ask facilities around credits, school credits, how those relate to their the curriculum that their child is already in, and will they get credit back home or not? Rights and protection, value and respect, skills, healthcare, and discharge planning. So key questions for families to ask are in that checklist. So if you have a minute and you're interested, feel free to download that, not only for your use, but to share with all the families that you serve. And Nashville may have already sent this out to folks connected with you. Thank you. We can go to the next slide. So we're going to talk about one example of a way to strengthen a children's continuum of care. And this was created in order to help children return home from out-of-home care as well as out-of-state care. And so the groundwork was laid with families. Families participated in leading the development of a white paper and holding focus groups with young adults and focus groups with families, offering surveys for young people and families to participate if they didn't really want to attend a focus group or participate more publicly. Roundtable discussions with residential and non-residential providers, and input from representatives of various national, state, local child serving agencies. So the groundwork was about, what did we find out in the literature review? What do we know? What are the conclusions in that? And then how do we use those to help shape our response and our services for children and families? Next slide. So using that paper as a guide to strategically advance the conclusions include reviewing and presenting local data and changing practice to bridge the principles and performance. Presenting local data with an eye toward outcomes, really when the focus is on outcomes, help to reduce fear. It helped people to overcome challenging community dynamics that were going on, and it informed more balanced discussions and provided an environment where it was safe to have those discussions and to develop solutions collaboratively. Next slide. So they established an ongoing work group with sort of the groups listed here. And I want you to think for a moment in your state, how often are residential programs part of community-based discussions and vice versa? So really using that opportunity to talk about where the gaps are, where those things happen that could either happen better or maybe happen at all, where families and young people sort of fall through and follow through doesn't happen. So really identifying gaps and other problems and thinking about solutions and strategies for best serving children when those things happen. That's a lot of discussion, right? If you're going to hear it from the family perspective, you're going to hear it from a youth perspective, community-based providers and residential programs, and the community organizations. Those are the other organizations who really provide a lot of ancillary supports for youth and their families as well. So maybe it's a program at the Y, maybe it's a Boys and Girls Club, to really invite the key players in the lives of children, youth, and families. Next slide. So to really get set, there was strategic development and expansion of community-based services. So based on feedback from all of those players, right, more key services were developed. In this state, they were family support services, MST, multi-systemic therapy, dialectical behavioral therapy, a transition to independence program, or similar to a transition to independence program, was developed for young people who had their own versions of peer support, and positive behavioral support and functional behavioral analysis. They also increased lots and lots of screening. Next slide. These are all pieces that help them get set for change. So once that happened and everybody was in agreement on the direction, it was then incorporated into the provider contracts and statements of work, items that reflected a team-based process that included families and principles around family engagement. There were expected outcomes from the treatment that got delivered, and new staffing models enhanced family roles within the family and provider organizations and the outpatient clinics. So once you really began to inform people and engage people in the understanding of the benefits of engaging families, a culture shift grew. You could actually feel it in the meetings. You could feel it in the rooms. You could feel it in the services as you read service descriptions and contracts. You could feel the change of the culture shift. Next slide. So those changes included funding providers in these categories. So they were funded to engage families in systems change and transformation, in supports and services for families, and in family involvement within their own organizations. That would be in designing programs, it would be in governance, it would be in making recommendations, in writing job descriptions, and being part of an interview team. It was the whole gamut. So really supporting family engagement throughout that system change and transformation project, or approach, I should say. Next. And they developed tools for success. This is a huge piece of work. I don't want anybody to think this happens in 2 months, right? It took a while. You had to change workflows to improve communication and coordination among those providers and to clearly map the decision-making steps for various levels of care. It included formally identifying families at the front and back door of services and throughout. So there were stages where families were doing some form of intake. They were the meeters and greeters. And they were having conversations and doing informal discussions for intake of families who needed services. And they were at the back door of services. So family support, family peer support was part of what you got immediately. No questions asked. You could decline it if you didn't want it, but it was available to you. Frequently asked questions for families who needed services so they knew more about the system and where to get what they needed. There were periodic practice review processes to ensure fidelity to the team and treatment planning process for children and their families. And they developed a dashboard focusing on national and local outcome measures. This is not a month-long process. This is a several month-long process. Next slide. And now we're at go, right? We get ready, set, and go. So they developed a plan to transition youth back to the community. I'm going to show you the roadmap in a minute. For those I may have lost along this discussion, I'm going to show you the roadmap. They use the CANs to guide planning for discharge. Many of you have a tool available to you that you use that could help you in your decision making. They focused on children who did not already have a discharge plan or a discharge date within 30 days. And they created a flow chart according to age group, level of placement restrictiveness, system involvement, and the complexity of behaviors leading to the reason for admission. So this was for all kids. This included therapeutic foster care. It included kids who are in out-of-state residential facilities. It included a good look at all kids who were out of home. And this is the way they began to narrow that population down, or actually to prioritize one by one as they took a staged approach. Okay, next slide. Other factors that they considered was the implementation date of prior authorization. The assumptions included that the resources would be there to administer the cans. And in order to do that for the numbers of children that they were talking about at that time, they actually had to employ people who could administer the cans, but didn't necessarily work for them. And so they contracted that work out to make sure that all kids had cans administered when they should. That team meetings were held within defined timeframes. We're talking about child and family team meetings. And that they had to accommodate the family schedules and locations. The scoring was reviewed internally, so the CAN scores came back internally. And the results were shared with the child and family team within 15 days of administration, so that planning for those children could be immediately after the cans. Next slide. So they shifted all of the children's out-of-home providers to a fee-for-service reimbursement funding model with tiered rates in accordance with the acuity level and the service need. And that change allowed funding to be freed up from residential to community-based care. So therefore, aligning with the treatment philosophy of serving children in the community at home and with their families. And we'll talk about that a little bit more in a minute. This is the roadmap. So I went through several slides a little fast because I really wanted to spend a little time with you on this. If you look at this, it really shows you the guiding factors around who would and would not be administered to. If the cans, if children did have a discharge plan and already had that in place, a family or a child and family team could request the cans be delivered to them as well. It didn't exclude them totally, but that isn't how they were part of a priority. The goal was to make sure that appropriate plans for children and youth who were currently in out-of-home facilities would happen. And the guiding factors that drove that plan were around principles, an overarching approach to care, and gathering that retrospective information for the team decision-making and planning for discharge. So the CANS was a huge foundation, as you can see. We used trained interviewers. The process that we defined is to the right. Protocols were established and a data sort by priority for each phase. And families were engaged throughout. This included training and information for families on what is the CANS? Why are you doing this with my child? How is it going to be used, right? So it's really important to make sure that you not only engage families, but you keep families really well informed as you make changes happen. So the first priority would be ages 12 and under. Level 1 was their highest level, most intensive level of care. And that would be to the left of the arrow. And all others in that age bracket would be to the right of that arrow. And as you can see, that progressed across the board. CPS is Child Protective Services. And Therapeutic Foster Care is TFC. Then when you begin to think about ages 17 and above, you're thinking about people who are approaching the adult system, right? They're going to be crossing the bridge to adulthood here pretty soon. So what if they have Child Protective Services involvement? They became a priority before the level 1 through 3. And then the therapeutic foster care, and the rest was based on the CAN score, right? Everything relied on the CAN score and the child and family team and treatment plans that could be put in place. Youth in specialized treatment might include youth who had sexualized behaviors. And so we then considered ages 13 through 16 by CPS, Child Protective Services, length of stay, right? Children aged 13 to 16 who had been there a long time. And we know from research, a long time does not necessarily mean positive outcomes. And levels 1 through 3, and then therapeutic foster care. And the youth in specialized treatment in that age group then were moved over to the next phase, where they were then brought back as services could be developed for them. More intensive in-home and community services. And that was sorted by Child Protective Services and length of stay as well. So for some of you who are thinking about that type of a change, you may have at least a draft roadmap to continue to think about that. We can go to the next slide. So the U2 outcomes for all system enrolled children improved across the board, improved. Because people were able to get those services that had been developed sooner. There was more focus on more services in the community. And so those are the positive outcomes for all children. The next slide has outcomes specific to the population we just discussed. So a reduction in children in the most restrictive care was by 66% reduction. Reentry rate for residential options within 6 months was 1, and that was at 17 months post-discharge. 50% monthly cost savings on residential care permitted greater reinvestment in other community options. So reliance on out-of-state placement shifted to focus only on specialized, highly specialized services not available within the state or as a treatment need tied to family connection and permanency. So for example, in those children who had Child Protective Service involvement, if there was an opportunity in a different state for another family member or a stronger family connection to support them, planning teams worked with that family to then move that child to their location. There were tools and lessons along the way, which is on the next slide. We realize that block capitated type of funding reinforces the opposite of the desired outcomes when you use it without a home care. This is probably something you already know, but it did, it not only was feasible, but ideal for the community-based portion of care. So keeping capitated funding for the community-based portion of care was positive, and moving to a fee-for-service model in out-of-home care was a better solution. Most intensive residential facilities also engaged in a self-assessment process using the Building Bridges tool and on-site audits for program improvement because they wanted to be the best they could be. And that's a wonderful thing. And we were delighted to see that happen. Families were crucial to the success and celebrated the experience of success with their partners. So, next slide. I've tried to talk fast enough for all of you who may have questions to pose your questions or thoughts, or anybody to say, yeah, I'd like to join a conversation specific to XYZ. Feel free to put that in the chat box as well, or speak up. I trust you can go off mute. Can people go off mute?
Yes.
Great, thank you. Are there any questions or comments? I'm relying on somebody else to tell me. How the inclusion of non-family peers can be beneficial as well. Absolutely. So if we're talking about the youth, are we talking about youth peers? Youth
Yeah,
peer support?
I meant youth peers or regular peer support specialists.
Right. Well, so for this particular project, and I would say family peers and youth peers were used, particularly around transition age, young people who are transition age, and really getting them involved with things like having a peer to help them apply for lots of things. First of all, did they want to move on in their education? Were they 17 and a half and they needed to start thinking about applying for their own insurance? Did they need to transition to new providers? You know, all sorts of things. And then the daily living things, lots of youth support for that. And when we talk about peer support for the parents, that's really people with lived experience, this similar lived experience doing that. And we've really discovered huge differences between adult peer support or peer support for adults and peer support for families of children. And so we really try hard to make sure that there's that lived experience piece when we talk about parent peer support. But all the peer support is crucial to the success of this, absolutely crucial. Any change you're making. And if you can, earlier I did a presentation for NASHBD talking about the positive outcomes from family engagement, and many of them relate to the functions of parent peer support. So if you're only funding navigation, it better have a really broad job description, or you need more than navigation. So for those of you who might want to look at that presentation, you can find it. I'm sure NASHBD can share where that is.
We definitely can. This is Leah. You know, as you were talking, I thought of so many elements of, you know, where a crisis begins, how we define crises. And I was also thinking about things that contribute to wellness. And in your experience in particular with families and young people, you know, things that people want to do that are more focused on self-care and health, whether it's sports or yoga or health activities, and kind of what has been your experience in being able to help families find ways to include that in their lives, because frequently those are things that are cost prohibitive and are kind of outside the realm of what people even consider as possibilities.
Right. And I think what's interesting is in community by community, it's different. But I will say, when you can go to a large company in your state or a corporation in your state, and you say, will you sponsor 10 memberships to the gym? Will you sponsor this monthly event? Will you, you're not then looking for a funding stream per se to make that happen. And you also, there's a great way to sort of get those people to then have almost a little challenge or camaraderie around that, right? To make it be fun and say, well, oh, you sponsor 10, I'm sponsoring 10, right? To sort of put a challenge out there. And pretty soon, and it doesn't have to all be to the gym, but it can be to those kinds of things that youth and families need. And in order to be healthy and to take care of their own wellness. And a big piece of that includes skills building and skills training as well. We have some funding through PCORI right now, and we're almost at the end of it, where we can share with folks what we learned. But in asking people what they want from mental health services, we've asked young people and we've asked families as well. And boy, many of the things they're saying are not about those services that you might think they're talking about. They want to know how to talk to one another. They want to know how to be heard by one another. They want to know how to have the complex conversations without fighting, So, yeah, that's a bit of a crass comment, but really that's what it boils down to, right? And how do you do that without it being a power struggle? And how do you negotiate win-wins? And how do you go to someone when you need help if you don't have a peer to reach out to? How can you reach out to your family? And how can your family reach out to you? Those are really crucial things around. Those are the relationships that are with us for a lifetime, whether they last a lifetime or not. They're with us for a lifetime. And so one of the things in the earlier publication I shared with you, those decisions around residential care last a lifetime. And families need to really explore them carefully because they do last a lifetime. Yeah.
Thank you, Pat. Any other questions in the chat or anyone else have a question?
I just want to say a huge thank you to everyone who came today and to those of you at NASHBD for supporting our work in this area. Next steps, I suspect NASHBD will be reaching out to let you know about the 10 one-hour Zoom sessions for one-to-one assistance in these topic areas. And I don't know, maybe they'd even like to hear from you what you'd like to hear about, where that's for states, policymakers, MCOs, providers, families, anyone who wants to have conversations with us and get some one-to-one time to strategize some solutions. We'll be inviting people with key experience to those conversations. I know some of the people we talked about would be Millie Sweeney, who trains and supports our parent-peer support model. Barbara Hopp, who's been a long-term mentor, friend. Mm-hmm. I once made the mistake of saying she was my boss, but I was really wrong. She was a friend to all of us in this work and a great mentor in the family movement, and other people to come and have conversations with you as you need. So thank you. Thank you, NASHBD.
Thank you, Pat. It's been great. This series has been amazing. And really, to me, there is no, there can be no progress without family voice and choice in every aspect of this work. And so I really thank you and FREDLA for the work that they do and all of your colleagues. I thank the folks for joining. And we definitely will be in touch with information about how folks can sign up for one-on-one discussions and consultation. So thank you so much. Take care now. Bye-bye, everybody.